Endometrial carcinoma will be the topic of our discussion here. Now, if you haven't watched my talk on endometrial hyperplasia, I would highly recommend doing that because endometrial hyperplasia is a precursor lesion to the most common type of endometrial cancer, which is endometrial adenocarcinoma. When you think of endometrial cancer, you should think endometrial adenocarcinoma. Don't assume it, but think it, because it is the most common type. But there are others. We're not going to go too deep into that. Primarily here we're going to be talking about things related to endometrial adenocarcinoma, but bear in mind that there are different types. As always, we'll start with a vignette. A 60-year-old woman presents to your clinic complaining of 3 months of vaginal spotting. She says that she notices the blood in her underwear just about every day. She denies any pelvic pain or pressure. She's nulliparous and has never used birth control. She has been married for 40 years and says that she's never had an STD. She's mildly overweight at 28.5, and she has prediabetes and hypertension, which is well controlled with captopril. She does not take any medications. She has never had surgery. Her last PAP was 9 months ago and was negative for pathology. Speculum exam is unremarkable. Pelvic exam is negative for masses or tenderness, and there is a small amount of blood on your glove finger. As you probably know if you've watched my lectures, anytime that you have a post-menopausal woman who is having blood coming out of her genital tract, you should always be thinking of cancer. 20% of women who have postmenopausal bleeding actually have cancer. So this should always be a red flag. And so the most common type of cancer from bleeding, that's going to cause bleeding, is going to be the endometrial cancer, which is the most common cancer of the female genital tract. Now, other cancers can cause it too. Certainly cervical cancer can do it, but she had a pap smear 9 months ago and it was negative. So no matter what, if she's got postmenopausal bleeding, we're going to be working her up for endometrial hyperplasia, i.e. endometrial cancer, is what we're concerned about. But we have to rule out other things. Now, she's 60 years old, but she's probably still sexually active. She's married. And we can never rule out pregnancy, even in somebody who's 60 years old. Now, this would be sort of the upper limit of when I would get a beta-HCG to rule out pregnancy. But it's such a cheap test, and it's so easy to get, and you want to rule it out because it is overall, pregnancy is a common cause of bleeding. So you get a urine HCG, it comes back negative as predicted. You're going to get a CBC to look for anemia, to look for a low platelet count, because that can cause and be an effect of bleeding. You get anemia if you bleed enough. A low platelet count can cause bleeding. That's unremarkable. You get thyroid function tests. Thyroid disturbances can cause bleeding. And then once that's all unremarkable and you have no reason to do any further labs, then you're going to get a transvaginal sonography. And this is done to measure the endometrial stripe. This will help you make the diagnosis of endometrial hyperplasia. Certainly a biopsy is the only way you're going to be able to detect that definitively. But if the endometrial stripe in a postmenopausal woman is more than 5 millimeters, the diagnosis, until proven otherwise with biopsy, is endometrial hyperplasia. That's too big of an endometrium for somebody who's not menstruating anymore, who's not going through her periods. Should never be more than 5 millimeters in a postmenopausal woman. Now, if you're talking about a woman who's premenopausal, then it's a little bit different. It can be very difficult to detect when she has endometrial hyperplasia and when she doesn't. In that case, we're going to more so rely on biopsy. Okay, so these are the important things here. Vaginal spotting, some of her risk factors, nulliparity, never used birth control, she's hypertensive. Not hypertensive right now necessarily, but she has a history of hypertension. And then you express some blood on your glove and the endometrial stripe, more than 5 millimeters, as she's a post-menopausal woman. I keep wanting to say postpartum for some reason. I don't know why. All right, so we'll talk about the essentials. sort of the pathophysiology, epidemiology, how this presents. We'll talk about how we work this up, how we grade endometrial cancer, not so much because grading is important for any test-taking purposes, but because you want to have an idea of how this is treated, and the grade is going to dictate how we treat cancer, endometrial cancer, and most cancers in general. The grade is what tells us how far we're going to go with treatment. And then we'll talk about the treatment itself and the prognosis. So the essentials behind endometrial cancer: it is the most common cause of cancer, the most common cancer in the female genital tract, and it is also the fourth most common cause of cancer overall in women. What's the number one cause of cancer in women? Breast cancer. But the number one cause of cancer death in women is lung cancer. Same with men. Lung cancer is the number one cause of cancer death in the US. Now, endometrial cancer is a very common cancer, but it's not a very common cause of cancer death. It's the fourth most common cause of cancer overall in women, but it's only the eighth most common cause of cancer death in women. So a lot of women will get endometrial cancer. 3% will get endometrial cancer. I think it's roughly 1 in 38 or so. So a little less than 3%, but a significant number of women will get endometrial cancer in their lifetime, but very few of them will die. Just a small minority, only about 20% or so will die from endometrial cancer who are diagnosed. In 2015, approximately 54,870 cases of endometrial cancer are expected to have been diagnosed. Of these women, only about 10,170 will die from it. It's still a decent amount, but in general, not a very common cause of cancer death. Of the endometrial cancers, 3/4 of them, possibly even more, I've seen up to 80-85% in the literature, are adenocarcinomas. This is far and away the most common cause of endometrial cancer, and they arise from endometrial hyperplasia. How do you get endometrial hyperplasia? The most common cause is a hyperestrogenic environment, namely those estrogen supplements that women often take after menopause. Once they hit menopause, their estrogen levels drop, and they experience vaginal dryness, hot flashes, etc. A lot of women will go on and take supplements. Those supplements raise your risk substantially of developing endometrial carcinoma, as well as some other cancers. So those come with their risks. The incidence of endometrial carcinoma is higher in white women, but black women have a higher mortality rate, and I think I can tell you the reason behind that. It might not be what you think. Okay, my tongue is getting twisted up here. So, some of the risk factors for endometrial carcinoma. There aren't a lot of risk factors for the other endometrial carcinomas, the less common ones, though, like serous cell and the serous carcinoma and the clear cell carcinoma. Those are much less common. The adenocarcinoma, though, has some very appreciable risk factors. So hyperestrogenism is the big one that you need to remember. And the one that, out of all the things that cause you to have more estrogen in your body, the one that is most associated with endometrial cancer is the menopausal estrogens that you take as a supplement. It raises your risk of developing endometrial carcinoma by 10 to 20 times. So that's the relative risk. Obesity, that's going to increase your risk because fat makes estrogen. Nulliparity, early menarche, late menopause, use of tamoxifen, and PCOS. Now remember, tamoxifen is often used in breast cancer. It's a selective estrogen receptor modulator. It acts as an estrogen agonist in endometrial tissue, but as an estrogen antagonist in breast tissue, and that's why it's effective for breast cancer. And then polycystic ovarian syndrome, why does that cause high estrogen? Because you're not ovulating. If you're not ovulating, you're going to be in estrogen imbalance. You're going to be having more estrogen, unopposed estrogen, less progesterone. Medical conditions associated with endometrial carcinoma include type 2 diabetes, hypertension, gallbladder disease, and then something called Lynch syndrome. Lynch syndrome is a genetic disorder. It is a cancer syndrome. It's a disorder where these people, it's clustered in families, they have higher risk for certain cancers. You'll often hear this referred to as hereditary non-polyposis something, HNPCC. But I don't remember what that stands for, HNPCC or Lynch syndrome. But it is associated with a variety of cancers, including cancer of the colon, small bowel, as well as the renal pelvis, ureter, and then also the ovary. And of course also the endometrium. So look for a history, whenever you're getting a family history in a patient, always ask for any cancer in the family. Everybody's going to say, oh yeah, my aunt had cancer, my great uncle had cancer, my cousin had cancer. That's not so much what you're concerned with. You're concerned about parents, siblings, and to a lesser extent grandparents. And you want to see if there's a predilection of cancer in the family, particularly the less common cancers. Yeah, okay, my grandpa had lung cancer and he smoked for 50 years. Yeah, that's to be expected. But when you have, my grandma had breast cancer, her daughter, my mother, had breast cancer, my sister has breast cancer, that raises some suspicion of things. Same here with, when we're talking about endometrial cancer, Lynch syndrome. If there's a predilection of colon cancer, kidney cancer, cancer of the ovary, especially when this is happening at a young age, then we need to be concerned about Lynch syndrome. It's not terribly common, but it's one of those cancer syndromes that you should be aware of. Another one would be something like Li-Fraumeni syndrome. Trying to think of other ones not coming to mind at the moment, but that's Lynch syndrome. So a little pearl there. White race is associated with increased risk. That stands for increased risk of endometrial adenocarcinoma. So it's 2 times. Higher socioeconomic status, not really sure why. Older age, your risk of endometrial carcinoma goes up the older you get. And then living in North America or Northern Europe. So all of these are also associated with endometrial adenocarcinoma. Or sorry, endometrial hyperplasia. They're also associated with endometrial adenocarcinoma. But these are all associated with endometrial hyperplasia. And you can imagine, because endometrial hyperplasia is a precancerous state in many cases, it is going to be associated with endometrial carcinoma as well. There are variants of endometrial cancer. The most common is the endometrial adenocarcinoma. And there are some other ones, 2 that you want to be aware of because the other ones are quite rare. So serous carcinoma, the thing to remember from this is that a lot of serous carcinomas are positive for the HER2 new oncogene. Where else do you hear about the HER2 new oncogene? HER2, so HER2 and new NEU. HER2 new oncogene. You hear about it in breast cancer. You always want to check breast cancers to see if they're HER2 new positive because there's a drug you can use called Herceptin. I'm trying to remember what the generic is and it's not coming to mind. Trastuzumab. So HER2 new is often positive in serous carcinoma, and experimentally we're looking into using trastuzumab for this type of cancer. It's the second most common type of endometrial cancer. And when it shows up on, I don't have any pictures. I'm not even going to go into how it looks pathologically, but I don't have histologic pictures to show you today. The clear cell carcinoma, you can imagine what that looks like on histology, but that's the 3rd most common type of endometrial carcinoma. Then there are some other ones, mucinous carcinoma, much less common, undifferentiated, much less common. Squamous cell, only several dozen have been reported. And then mixed type is a little bit more common, but it's all it is where you have features of both, of more than one type. Okay, but endometrial adenocarcinoma is the one I want you to remember. And then also, if you can, remember that serous carcinoma is associated with positive HER2 new. Not all of them, but a lot of them. And then a lot of times this is divided up into types. I don't really know why they do this, but they refer to endometrial adenocarcinoma as a type 1 endometrial carcinoma, and they'll group in serous and clear cell carcinomas as a type 2 endometrial carcinoma. I'm not sure where mucinous and undifferentiated fit in with that, but you'll hear that get thrown around. I wouldn't worry about that for the test. So, some differences. So with type 1, the endometrial adenocarcinoma, it is associated with unopposed estrogen, and it's also responsive to estrogen. So we use progestins in the treatment of endometrial adenocarcinoma. If on the USMLE test, if you hear endometrial carcinoma in a test question, you should just assume they're referring to endometrial adenocarcinoma because it's the most common, but they should be specific. It's also a slow-growing cancer, so it's associated with a better prognosis because it grows slower. You have more time to realize that, oh, look, I'm bleeding. I should probably go to the doctor. The vast majority of these cancers, the adenocarcinomas, are discovered in stage 1. So it is associated with a much better prognosis than the type 2, which is a more rapid growth. The precursor lesion to the adenocarcinoma is atypical hyperplasia. Remember the difference between typical and atypical. Atypical is associated with a higher risk of cancer. The histology is endometrioid. It's got a lot of those little channels and glands that form, and they group together and sort of take over. The grade tends to be low on diagnosis, grade 1, grade 2. The depth of invasion is usually pretty superficial. It doesn't often penetrate the myometrium, and even when it does, it's generally very little. Age at diagnosis, relatively younger. So these women tend to be around the age of menopause, maybe plus or minus 7-8 years, but they can certainly be older. The genetic changes include aberrations, mutations to the PTEN and CRES genes. Don't worry about that. Now the type 2, which is the serous and clear cell carcinomas, they are not associated with estrogen. So this can happen really to anybody. It's not associated with hyperestrogen state or anything like that. It's also not estrogen responsive. These tend to grow faster. They grow on focus of atrophic epithelium. They also are often high grade at diagnosis, probably just because they grow faster. They often penetrate deeply into the myometrium and the uterine tissue, and these patients tend to be older. Okay, how does this show up? So the most common presentation of endometrial carcinoma is abnormal uterine bleeding. So in a premenopausal woman, that could be menorrhagia, intermenstrual spotting. Now when you get closer to menopause in that what they call perimenopausal years, what should normally happen is that the periods should get further apart and they should get lighter. So if a woman is having her periods, she goes into perimenopause, she's having her periods further apart and they're lighter, and then suddenly she starts having heavy periods or more frequent bleeding, that is a red flag for something going on. Postmenopausal women shouldn't have any bleeding at all. So if they have any bleeding whatsoever, the next step is going to be to look at the cervix, look at the vagina, look at the vulva, and look to see if there's any kind of lacerations, sores that may be causing the bleeding. Otherwise, we're going to assume that the bleeding is coming from the uterus and that this is abnormal uterine bleeding. 20% of postmenopausal bleeding is due to cancer, so we always have to keep an eye out for that. A detailed history is going to be useful in determining the patient's risk for endometrial hyperplasia and cancer, so you want to know if she's ever used estrogen supplements, if she's ever used tamoxifen, if she's got a history of breast cancer and used tamoxifen for any reason whatsoever. If she's nulliparous, the more babies you have, the more times you're pregnant, the less likely you are to develop endometrial carcinoma and hyperplasia. When did she have menarche and when did she have menopause? Early onset menarche, late onset menopause are associated with endometrial cancer. Remember the average age of menarche in the U.S., 12.4 years. Average age of menopause in the U.S., approximately 52 years. It's going to be earlier menarche if you're fat, later menopause if you're fat. So That's why obesity is associated with endometrial cancer. And then gynecologic problems, namely PCOS. So working this up, we will get a qualitative HCG to make sure she's not pregnant, which is certainly a common cause of bleeding. CBC to look for anemia or low platelets, thyroid function tests, and ensure her PAP is up to date. Because remember, another cause of bleeding is cervical cancer. So we want to make sure that she does not have that. Imaging, that's going to be our next step, and that is done via transvaginal sonography. That's the imaging test of choice. In postmenopausal women, a thickened endometrial stripe is suspicious for endometrial adenocarcinoma, as it's diagnostic of endometrial hyperplasia. The threshold is 5 millimeters, so if it's any more than 5 millimeters, we consider that endometrial hyperplasia, and our very next step is going to be to get a biopsy. In premenopausal women, it varies. So the problem for premenopausal women is that their endometrial thickness is going to vary depending on where they're at in their cycle. When they're menstruating, they tend to be around 4 or 5 millimeters. When they're in their secretory phase, when they're most fertile, they tend to be around 14, 15, 16, or even more millimeters. So there's such a wide variance, it's very difficult to know a cutoff of when we decide they have endometrial hyperplasia. So what ACOG, the American Congress of Obstetricians and Gynecologists, have recommended is whether or not you go forward with a biopsy is going to depend on their risk factors. So a woman who you suspect endometrial hyperplasia based on her history, who is older than age 40, you're going to go ahead and get a biopsy. If she has risk factors for endometrial cancer, so let's say that she has a family history of colon cancer at a young age, family history of endometrial cancer, family history of ovarian cancer, that would certainly be make you decide to go forward with it. Or let's say she's got PCOS. That's another risk factor. Let's say she's morbidly obese, or she's diabetic, or she's got hypertension. Those are all risk factors. So assess her risk factors. If she's got risk factors, go ahead and do it. If she fails to respond to medical treatment, so when we talk about endometrial hyperplasia, that's a diagnosis. A lot of times we will, or even let's say she's got abnormal uterine bleeding and we put her on progestins and she does not stop bleeding, then you could go ahead and get an endometrial biopsy to look for something more nefarious. And then another one would be if she's got significant intermenstrual bleeding, if she's bleeding a lot, if she's got menorrhagia, metromenorrhagia, and so forth. Okay, so once we decide to go forward with the biopsy, and I'll just have you know, by the way, that on a test question, when you get a vignette, the woman with endometrial carcinoma or suspected endometrial carcinoma, they're going to give you a postmenopausal woman. I can almost assure you. So look for that 5 millimeter cutoff. Once we go forward with the biopsy, endometrial sampling is done. This is just done with a little pipette. You stick the pipette in there. There's a little piston in the middle. You pull that piston back. Once you hit resistance, that's going to bring suction and allow you to pull the tissue into the pipette. You twist the little pipette around, kind of pull it out, manipulate it in there, and then once you pull it out, you should have a little wad of tissue that gets sent off for biopsy. Okay, so going back to the transvaginal sonography, it's important for clinical purposes that you're aware of how to do this, especially if you're a primary practitioner or especially if you're an OBGYN resident. You want to know how to measure the endometrial stripe. So it's quite simple. All you do is you take so you're looking at the uterus, you want to look in a sagittal plane, and you look for a border, this border between echolucency and echogenicity. So you kind of see here, this little, it kind of looks like a finger-like shape here. This is the border between the myometrium and the endometrium. Okay, so this is endometrium here, this more echogenic colored tissue here. Okay, so this echogenic layer is where is the endometrial layer, and all you do is you measure it from side to side, so from here to here, and the number of millimeters that is going to be your endometrial stripe. So outer edge to outer edge. Okay, you can see here it's a little bit more difficult. So here is our echogenic, the edge of our echogenic layer, and then here's the other edge. So from edge to edge, and this actually comes out to be about 1.4 centimeters. So 14 millimeters. Now, certainly, we would have to know the age of the woman. If this isn't a 25-year-old woman or a 35-year-old woman, this could be perfectly normal. If this were in a 60-year-old woman, this is certainly abnormal, and your next step is going to be a biopsy. This is endometrial cancer. So if you looked at some of my lectures on other things that can go wrong in the uterus, what might this look like? This looks, especially if it's within the tissue, growing within the tissue, this can look a lot like adenomyosis. And it can be very difficult to tell the difference. So typically with adenomyosis, look for penetration into the tissue, but endometrial cancers can do that too. So you have to go by your history. If there's any doubt, get an endometrial biopsy. And it's the Doppler that's helping you here. Now, how would you tell the difference between an endometrial carcinoma and a fibroid? Remember that the fibroids are going to have that, the Doppler flow is going to be on the outer rim more so, rather than penetrating into the middle. This is more confluent throughout the mass. Oh, and also polyp. So remember, a polyp tends to have that feeding artery that comes in. This does not. And a polyp is a very common cause of bleeding. So that's another thing that's going to be on your differential. Oh, and also, I should say, adenomyosis, you're not going to see it in a 60-year-old because it's estrogen responsive. And so with adenomyosis, it should go away once you hit menopause. All right, so to work this up, once you have diagnosed a woman with endometrial cancer, once the pathology has come back and it's diagnosed with endometrial cancer, your next step is to stage it. When you see the pathology, it's not going to tell you how bad the endometrial cancer is because all you're doing is looking at it with from the uterus. It doesn't tell you how far it's spread. So the next step is to determine how far it's spread. And so you're going to, the mainstay of your diagnostic process is going to be a TAH-BSO, total abdominal hysterectomy plus bilateral salping oophorectomy. So you're taking all the female organs out, and primarily why we're doing that is we want to remove all the endometrial tissue. We want to remove any local area where this could have spread to, and certainly the adnexa and the ovaries can be a place where this spreads. So we want to take all that out. We also want to get peritoneal washings. So all that means is that once you get in to the peritoneum, you're going to inject some saline in and then aspirate that out and send it off to pathology. And then you're going to remove pelvic and para-aortic lymph nodes. And the reason for that is because the prognosis and treatment plan is going to vastly differ depending on whether or not we have lymph node involvement. Once the uterus is removed, you should open it up and assess for the degree of myometrial invasion. Most of the time there isn't much, but you want to look anyway. Other tests you should get is a chest x-ray looking for metastasis to the lungs. It's one of the most common locations of metastasis for endometrial cancer. The other place would be the liver. And then get CA-125 levels. Higher CA-125 level is associated with more cancer. CA-125 is good for assessing also the response to treatment. However, it's not good for screening healthy women where we don't expect endometrial cancer. So it's not a good screening test for endometrial cancer, but if you know the woman has endometrial cancer, then checking her CA-125 levels is a good way to determine if she's responding well to treatment. So here's endometrial carcinoma. This is in well into the myometrium, so this would be a stage 1B at the very least, but we don't know because it depends on if there's any metastasis or lymph node involvement. This is not the focus of the tumor here with the asterisk. This happens to be a fibroid. Okay. So here's the tumor here. We can't really see how deep this goes though, but you can see there's definitely not any involvement out here. So no involvement here. Looks like this is the tissue underlying the tumor, and there's no involvement. No myometrial penetration. So this would be consistent with a 1A, which is the least severe form of endometrial carcinoma. Like I said, most are discovered in stage 1, 75% actually. Okay, so for staging, don't memorize this, but at least remember sort of the progression here. So stage 1, the tumor is confined to the corpus uteri, which means the endometrium and the myometrium. So stage 1A means less than 50% myometrial invasion. Stage 1B means more than 50% myometrial invasion. Stage 2 means that the tumor invades the cervical stroma, but it doesn't extend beyond the uterus. Okay, so it's a little bit, it's spread a little bit, but it hasn't gone outside of the uteral cervical complex, for lack of a better word. All right, stage 3 refers to local spread of the tumor. And this can spread to various different places, and they get worse the further you go. So stage 3A means that it's involved the serosa, the outer laying of the uterus, the adnexa, or the peritoneum. So when we get those washings, if there's positive cancer cells in those washings, then it's a stage 3A, regardless of how deep it's invaded the myometrium. Stage 3B means it's involved the vagina or the perimetrium. Stage 3C means it's metastasized to the pelvic or the para-aortic nodes, and this can often be split up into stage 3C1, which would be pelvic, and stage 3CB, which would be para-aortic. So this has a worse prognosis than 3B, which has a worse prognosis than 3A. Stage 4 means that you have metastasis to the bowel or bladder or beyond. So stage 4A is metastasis to the mucosa of the bladder or bowel. Stage 4B is distant metastasis, which can include abdominal structures like the liver and or inguinal lymph nodes. Now, when you have a patient where there is apparent invasion of the cervical stroma, then in that case, and the way you'd be able to tell that is grossly, but in that case, you're going to get an MRI because you want to look for other spreads. If you have a stage 1 tumor, no involvement of the cervical stroma, the pelvic and aortic nodes come back negative, peritoneal washes come back negative, you can rest assured that that's a stage 1, and that the chest x-ray is negative. That's stage 1. But if it's stage 2 or beyond, you should get an MRI. CT, MRI, not routinely done for the general workup for endometrial cancer. Okay, so here is stage 1. So this is just something I found on Wikipedia. So stage 1 is restricted to the endometrium and the outer 50% of the myometrium. Stage 1B has penetrated further than the midpoint of the myometrium. Stage 2 has grown into the cervix. Stage 3A involves the adnexa. Stage 3B involves the vagina, and stage 3C involves the nodes. Okay, so note how this spread to the ovary. It doesn't have to spread this way, but this actually involves the serosa too. But it can also involve the tubes. And the most common way, by the way, for endometrial cancer to spread is through local invasion. But it can also spread hematogenously to distant tissue, like the lungs and liver and bone. And it can also spread, obviously, lymphatically. And then stage 4A is going to be to the bladder and bowel, and then stage 4B is going to be distant, out to the liver, bones, lungs. How do we treat this? So it depends on the stage, of course, but for all of these patients, we're going to go ahead and remove all the female organs. We don't have to remove the cervix, provided that there is no cancer in the cervix. But you want to remove the uterus, the tubes, the ovaries, remove it all. And then you also want to remove pelvic and para-aortic lymph nodes because you want to check to see if those are have received metastasis, because that's so common, and then remove any visible malignancy that you might see. Once you do that, you stage it. If it's stage 1, you don't need to do any further treatment. Now, if the patient happened to be a poor surgical candidate, then you could do radiation. But for test-taking purposes, stage 1 endometrial cancer, once you've staged it and you've taken all those organs out, taken the lymph nodes out, taken any visible malignancy out, you're done. If it's stage 2, you will typically do radiation. Now, the book that I read said that radiation is actually controversial for stage 2, but other sources have referred to it as though it's done commonplace. And so what I'm thinking is probably that there are a lot of newer techniques for radiation, newer technologies, where there are fewer side effects, and so it's being done more and more. But stage 2, most physicians will do radiation, most oncologists. And then stage 3 and 4, chemo and radiation. So for chemo, the protocol that's most commonly used is the TAP protocol. TAP stands for Taxol or paclitaxel, adriamycin, brand name for doxorubicin, and platinum or cisplatin. I suppose you might be able to use carboplatin too, but these are the 3 that are most commonly used. And remember, trastuzumab can be used in serous carcinoma. Progestins are often added to this therapy. All right, so the prognosis is actually quite good most of the time. So remember, the majority of cases are discovered in grade 1. And so that has a 5-year survival up to over 90%. So between 75 and 91%. If there's no minimal invasion of the myometrium, the survival is excellent. It gets worse the further up the grade gets. So if you have distant metastases, you can imagine the survival is quite weak, only 5 to 15%. But the majority of women who are diagnosed with endometrial cancer, they do quite well. And remember that even with grade 1, a lot of times you're not doing anything else other than TAHPSO, and you're removing nodes and everything. So once you're done grading it, and you know you have a grade 1, you don't really have to do anything else, and the woman can rest assured knowing that her prognosis is quite good. One more thing I wanted to bring up. Now, if a woman has stage 1A cancer, and there is no myometrial involvement. So remember, 1A means that you have less than 50% myometrial invasion. But we're talking here, if she's stage 1A and she has no myometrial involvement, in that case, she is a candidate for fertility-sparing treatment if she so elects. So let's say she's 30 years old, very young to get endometrial cancer, but if she's 30 years old, she has endometrial cancer, she wants to have babies, what you can do is you can say, okay, have babies ASAP. In the meantime, if you're not going to have babies right now, then you put her on megestrol acetate, 160 milligrams every day, and monitor every 3 months with endometrial biopsy. But preferably have kids as quickly as possible. Once she's done having kids, you're going to be removing everything. Now, I am not exactly certain, to be honest, how you make a definitive diagnosis of 1A, stage 1A cancer without doing all this stuff. So you may want to ask a OBGYN if you get the chance. But that's just a pearl. If she's 1A, stage 1A, and she doesn't have any myometrial involvement, then you may go ahead with fertility-preserving, fertility-sparing treatment if that is something that she's interested in. All right. If you have any questions, write me a note below, or I'll see you next time.